So yeah, I'm Shahram Yousefi. First of all, thank you, InnovatorMD, Dr. Yuli, and everybody else for organizing this. Thank you for all the attendees, because without you, this wouldn't have the value it has today. And thank you to the judges. So I'm going to talk to you about Mesh AI and what we've been doing to try to put health back into healthcare by empowering physicians through better schedules. Okay. So my story began a little while back as an academic. I'm a university professor, former department head, and former associate dean of an Ivy League school in Canada and UC Santa Cruz here in California, where I'm based out of Bay Area. And from a near fatal incident in healthcare that had to do with fatigue, that had to do with the scheduling error on a spreadsheet, to today, where we're actually saying no, turning customers around because we're beyond capacity. And these are people who need us. So that's my biggest motivation to be here. I'm a proud member of InnovatorMD community, but I'm really excited to tell you where we are today and get your help so that we can serve more people in North America. So starting from our beyond my incident, why I got really excited about this problem as a researcher in telecom algorithms, AI, ML, to become, a person who's fighting for physician wellness and happiness in healthcare today. Some of the numbers that excite me is, as you probably know, the largest budget item in the US for healthcare, which is 22% of GDP, is actually hospital care component at about $1 trillion. And now that, the largest cost component is the cost of people involved. And when you think about that, it's quite ironic that the most mismanaged component of healthcare today, by so many other research pieces and so many ways of looking at it, is actually the people component as well. So what we've done is that we focused on collaborative clinician scheduling, which is a new paradigm to achieve efficiency, quality, and wellness in healthcare, quintuple aims of healthcare. We truly believe the common denominator is wellness and happiness of people in it, the physicians, residents, fellows, and nurses, and other HCPs. So that's what we focused on, bringing augmented intelligence as a whole to make this space different. Some of the other numbers that drive this for me and get me excited about work in the past decade, where this began as an academic project in my lab 10 years ago, and then the past 2-3 years post-pandemic, we've been growing very rapidly. It's things like 500,000 people that die from medical errors in the US. Fatigue has a big component of that. In fact, 65% are connected to fatigue. And 3 US physicians, and it's just focusing on physicians, committing suicide every day in the US. Nurses are not that great. Burnout is great, 63%. And then you look at nurses, just the churn, 33%, about 1/3 of nurses left in 2022. The numbers for the other years are not much better. How do we fix all of these issues? Again, we think the common denominator has to do with empowering physicians. You look at the history of healthcare in the past 100 years in particular, you can see that physicians have been losing control and power year after year. And we think that has a lot of aspects to it. And a big component of that is hours of work and how they participate and how much admin work they do. On that, in particular, clinician scheduling is what we believe that currently is being done 100% correctly. We need to do collaborative scheduling in healthcare, because healthcare is going to be always human-centric, and clinicians are the core components of healthcare. And we believe to do so, we need to design healthcare schedules that are fair, but transparently so. Fairness and equity do not matter unless people see it and believe it. So we believe with that, we can save admin time, which is one of the killers of productivity and actual human beings in healthcare, reduce burnout, improve patient experience, save lives and money. So how do we do that? Currently, just for those of you who might not be really involved in this space, I want to share with you that the majority of physician resident scheduling, so look at teaching hospitals, when you have preceptors and learners combined, the majority of that currently is being done on spreadsheets. 74%, when we started the work academically 10 years ago, a number today is about 60%, are still using spreadsheets or something as manual as that to schedule people, which is fundamentally incorrect. So what have we done? We have built a trio of a web app, iOS, Android app that based on subscription that are monthly or annual. We also offer 3-year grants, 3-year plans that are becoming more and more popular with hospitals and healthcare systems. What we deliver is fair, transparent, one-click scheduling, which is not possible for some of the problems we manage today with other systems, competitive systems out there. And I can talk about competition later on that comes up. This is a very crowded space, but we have found a very niche and unique angle to it, and we're growing very fast. We do call clinical scheduling, and increasingly now we're getting to OR block scheduling in the context of PGME programs. The system, one of the unique features of the system is that it's uniquely customizable to manage very complex schedules that others can't afford or don't want to support. So that's what we do today. But where are we going with this product? The future, books of Amazon for us is the multimodality of healthcare, being able to be the OS of a scheduling for all people, all HCPs in healthcare today. When we have hospital at home, home healthcare, virtual health, regular health, all of that combined and run by the same people, theoretically. Our differentiators and moats today in this crowded space are these quadruple. Our automation engine, when thousands of rules we've built since 2015, that's one. Ability to do full customization of the workflows that are quite unique as fingerprints almost these days when you look at different scheduling problems we look at. And a number of product features that we've developed over the past 4 or 5 years that do what we call glass box scheduling as opposed to black box scheduling, which is calendars, spreadsheets, Amions, QGendas. They're all really black box schedulers. They don't provide the transparent fairness that we focus on. And we have established connections to 540 hospitals already in Canada and US. I'll tell you a bit more about our traction. So those are really our strongholds. When software gets into a space and gets sticky, it's very hard for healthcare systems to move away. So we're really banking on that. In terms of our GTM traction and success, our ARR is about $500,000, $450,000. We've done that post-pandemic in the past 2.5, 3 years. And current funnel that we're looking at right now is $6 million. Involves really stars of healthcare that I can potentially talk about later on. We spend about $2,000 on an average unit with an LTV of $18K in terms of that acquisition. 85% of referrals are people like Gary and other doctors here, Dr. Yuli, who recommend the system that they've used to other people. That's our #1 driver of growth. We have about 100 accounts right now touching 480 hospitals. And I want you to pay attention for a PGME program. When we go, for example, to family medicine of Stanford University, we're not in one hospital. We're going to touch a number of hospitals as a result of that. We've had about 100% revenue growth year over year. So it's about 10% month over month growth and 120% in our team. And in fact, growing our team right now is our #1 challenge. Our demo conversion was higher, but now that we're doing a lot more demos, it's come down to 50%. About a year ago, it was 74%. And we convert in 2 months. So that's, I think, one of the unique things about us, that we don't do a lot of champagne, chocolate, and dance to be able to actually go from demo to have the product in the hands of customers. We've had a ton of success. We've come first or second in every competition we've participated in the past 2 years, from Charm Health Innovation last year that we came first, all the way to a previous IMD event. American Medical Women's Association picked MESH-AI as scheduler of choice because we impact equity, diversity, and inclusion for women, make healthcare a better place for women and minorities. Really excited about that. The other thing to share is some of the hospitals we're at. We're in discussions with leading healthcare systems at the moment. We're in operation, in use at places such as Stanford, UCSF. Because I'm out of Bay Area, I'm making the connection to Bay Area, but we're coast to coast in Canada, US. And we're in talks with 5 of the largest healthcare systems in Canada, US at the moment. Those are going to be champagne and chocolate in 12 months advance. So we're ready for that. We're doing that, and RFPs. And we're also in talks with 2 private equity. We've never raised money. We've been growing this product really with our physician users, with customers' money. But the fact that private equity is looking at a company that is making about $500,000 in ARR, it really shows how strategic we are in connection to other bits and pieces of software that are needed in healthcare. So that's really their attraction to us and where we are, the product and where we are. We've had a lot of coverage by the media. I'm not going to talk about that. So the specific segment we're targeting right now, the PGME, GME, complex physician schedule, is about $120 million. I can give you the calculation. That's actually very conservative. But the larger HCP, without even calculating the multimodality, things such as hospital at home, it's a $2.5 billion market per year. And we're looking at Canada and US at the moment. Who we are, I'm a 21-year academic, as I mentioned, former department head, associate dean in engineering. My expertise is at telecom. I'm a mathematician, more than 100 papers and patents over the past couple of years.
All right. Thank you, Shahram.
Just the last one. My co-founder is a neuroscientist. Thank you. And that's my team. And this is a team of our advisors. And I want you to join us as we're making healthcare a better place. Thank you, Yuli.
All right. Let's go with Jay. Do you have any questions or comments?
Oops, it's a little bit of a question and a comment. I would love to have learned. I would have loved to have stolen some of the time explaining to me how bad the situation is in favor of, I think you're probably onto something around this glass box versus black box. But if your purpose was like, don't show the audience the actual shark in Jaws until the end of the movie, you did a really good job. Except that now I'm sitting there, I'm dying to really get in and sink my teeth into what your technology does. Because I think unless you're a scheduler, which your average venture capitalist is not going to be a scheduler, I'm sitting there thinking, you're probably onto something, but I don't know what it is because I didn't get to see the shark. And now I'm going to get popcorn and the movie's over. So just an observation that you probably did a good job getting my curiosity up, but I don't exactly know. So I'll turn this into a question, maybe in just one bullet. What is collaborative glass box scheduling? Like that doesn't really get answered throughout the presentation, at least as hard as I was trying to listen.
Thank you so much, Jay. So the teaser worked. I hope I'll talk to you after this. We've talked to Gary a bit in the past. But I think the key thing in healthcare is that we usually tell people to tell us their preferences, we look at their qualification, and we go ahead and schedule them. Now, whether or not the chief of anesthesiology is doing the scheduling herself, or we have a team of schedulers doing the scheduling of hospitals at John Muir Health, or whatever. At the end of the day, the inner workings of a schedule are never shared. So the way we do this is that we let people put into the system as far away as their daughter's piano recital next week. So all of that data goes in, and we have also insights from the past, and that comes in, and all the rules and regulations that are contractual, sacrilegious come in, and those three bits and pieces of information or pipelines of data come in, and then we got a very hard mathematical problem that people can't typically solve well. We do a decent job. We can't cover the entire market there, Jay, but we can cover about 70, 80% of the market. So we disqualify about 20, 30% of demos we do. We're very honest. This is not as much better than Lightning Bolt. This is not much better than QGenda. Stay where you are. But when we are, people come to us to really move away from QGenda, Lightning Bolt, and other schedulers that are still taking 20, 30 hours of their time to something that takes 2 or 3 hours. So that's the whole idea. When the schedule comes out and people think, oh my God, I used to do 3 night calls. Why the heck am I doing 5 in August? There's an explanation attached to it. So that's the whole idea.
I love that.
Yeah.
Thank you.
Pleasure.
All right, Gary, question, comment?
Okay. Well, I mean, I'm standing here in front of a list of potentially 300 questions, but we won't go down that path.
1 minute.
And yeah, and by the way, Jay, we do have a venture capitalist who is an expert in this area who did scheduling for a group of like 45 anesthesiologists across 5 hospitals with QGenda.
It's up to you to fund the company then.
Okay, so I guess if I'm going to focus in on anything, and again, there's so many questions from technology all the way through deployment, is first of all, do you have intellectual property for what you've built? Because you have a huge, as you pointed out, number of competitors, and one like QGenda, who is in a significant number of hospital systems and large practices. So what's your market differentiator, and how is that protected? Why can't QGenda do this themselves?
If they could have done it. So I will talk about it, Gary. I think what has to do with our process, a lot of our innovation is also in terms of our process. And I think you touched on it. The whole process of setup, like QGenda, like is very typical. Fill from demo to full launch, that could be 12 months. For us, it's a lot shorter. We're talking 2 to 3 months, and that has to do with how we use technology to figure out the problem of the scheduling they're dealing with. And Gary, you probably know that. Most people don't know what they want. So specifically when it comes to scheduling, when we talk to the chief of anesthesiology, who's been doing this on a spreadsheet and calendar for the past 15 years, and she thinks she's really good at it, but she still spends a lot of time on it. When we actually meet with them and say, tell me how you schedule, they only give us 70%, 80% of this stuff. The rest is in their head. So we have a very good way of taking that and very inexpensively building it into the system. I think that's one of the key differentiators for us. We do not have IP. I don't have enough money to prosecute, so my path is, rather than doing that secret sauce, go forward. On that note, QGenda, Lightning Bolt, all of them have taken note of us. We just had a meeting with leadership of Lightning Bolt last week. So they're very interested to know what we're doing, and that's a really strong sign. And they actually see us as complementary, Gary. We look at some of the problems that, in fact, QGenda, Lightning Bolt are aware that they're not doing well, and they're not going after in terms of segments. So, for example, they're not actively pursuing the PGME scheduling, the ACGME environment that we are actively pursuing for a number of reasons.